types and associations.
One of the most interesting and important of the congenital optic disc malformations is elevation of the optic disc. Okay, this is not advancing. Okay, there we go. My objectives are to describe these various causes of congenital elevation because they aren't all the same, and to discuss how you can diagnose these different things. This is perhaps the most important slide of the talk. These are the causes of congenital optic disc elevation, drusen, which may be visible or buried, and I'll show you those in a moment. An underappreciated cause is simply without any drusen. The discs are just congenitally elevated. There's nothing special about them. However, they may be from another anomaly such as hypoplasia or a tilted optic disc. So what are optic disc drusen? They're calcified bodies within this anterior disc surface. They're always located anterior to the lamina fibrosa. I'll show you some histopathology in a moment. And when they're visible, they look sort of like what the Germans thought was rock candy, and that's where the term druse comes from. And they become more obvious over time. So initially, they may not be obvious, and then as the person ages, they become more obvious. So here are two histopathologic examples, and I'll just draw in for you the lamina fibrosa, and you see that all of these calcified bodies are anterior. If you see something posterior to the lamina with, say, an EDI OCT, that's not a druse. The prevalence has varied depending on what sort of modality you use. There was a very nice paper this year in which they looked at the prevalence estimates of drusen depending on what type of procedure you did, whether it was ophthalmoscopy alone or fundus photography. And it turns out the spectral domain enhanced depth imaging, OCT, gives you probably the correct or a fairly correct prevalence of about 2.25%. And that goes along pretty well with the histopathology as well, which is somewhere in that range of about 2% of patients having disc drusen. One of the most important aspects of optic disc drusen, and this is true whether they're visible or not, is that they shouldn't cause loss of visual acuity unless there's some sort of vascular process or something else going on. So yes, we do see central retinal artery occlusions, we do see branch artery occlusions, we do see ischemic optic neuropathy, CRVO. But in fact, if you just see a patient with optic disc drusen who's losing visual acuity and there's nothing else in the fundus to explain it, you'd better look for something else. And indeed, it used to be thought that patients with drusen were more likely to have brain tumors. That's been shown not to be the case, but you can imagine that the patients are well worked up when they have a funny looking disc, so you're more likely to check them. These drusen do reduce blood flow in the optic disc vasculature, and there's actually on OCTA, you can see a reduced peripapillary vessel density. 88% of drusen, whether visible or not, are associated with visual field defects. It used to be thought that the field defect did not correlate with the position of the druse, but in fact it does. The worse, the larger the druse are, the more extensive they are, the more likely they are to be associated with an extensive visual field defect. So what do they look like? Here you can see the rock candy-like substances in this patient with bilateral drusen, and here's the severe visual field defects in the two eyes associated with these drusen. The pathogenesis is well worked out. Mark Cho reported this back in the 80s. These are abnormal mitochondria that become calcified. They extrude their innards, and more calcification develops. They can be easily seen really with simple ophthalmoscopy, but if you want to see them even better, you can put a red-free filter in your ophthalmoscope and look with that, or on a fundus photograph. Autofluorescence can also be seen. Here's a red-free photograph, and here's a regular photograph with autofluorescence. Very nice way to see these. There is no leakage from optic disc drusen, but there is late staining. And so those of you who want to do fluorescein angiography, it's not an unreasonable thing if you're not sure. The long-term prognosis is really interesting. There were 8 patients originally described and studied by Lorenzen back in the 60s, and they were followed up all these years later. And the median follow-up time was 56 years, so this is a long follow-up. And really, there was no major change in the appearance of these visible drusen. I'm not talking about the deep drusen that I'll talk about in a moment, but there was no real change in the appearance, and there was only a very mild decrease in visual fields as performed on a Goldmann perimeter. So pretty much when you see visible drusen in a child, or even in an adult, that's probably what you're going to get over time. Well, what about buried drusen? By definition, these are not visible with the ophthalmoscope, or maybe you can just get a sense that something is going on. But the big issue is that these mimic true optic disc swelling. And since the visual acuity tends to be normal in these patients, and if you especially haven't done a field or a field defect is minimal, you may mistake the elevation of the disc for papilledema. And that is the biggest concern that we have when dealing with patients with elevation of the optic disc. You can detect these buried drusen with a bunch of different techniques, OCT, ultrasonography, or CT, but MRI, while it's good for a lot of different things, is not good for buried drusen. OCT is probably the easiest, although my colleagues at UCLA did a very nice study in kids that suggested that fluorescein angiography actually was the best way to detect drusen causing elevated optic discs. So here you can see this, and you might look at these photographs and say, well, that looks like real disc swelling to me. And I would have been concerned as well, but look what happens over time. These are the same discs, right and left, and you can now see the drusen that were buried before this. EDI-OCT is really a great test for buried drusen. All of the studies of a large group that looks at drusen have shown that EDI-OCT really is very, very helpful. It's more accurate than ultrasonography, autofluorescence, etc. Although in one of the studies, they didn't test it against fluorescein angiography. So I don't know that necessarily it's the only thing. But if you have EDI-OCT and you have a population that may have optic disc drusen, this is a really good test to do. Ultrasonography can be used to diagnose it. This was a 21-year-old man with headaches and was sent to me for possible unilateral papilledema. You can see a somewhat small optic disc, but otherwise normal on the right. And this obviously elevated disc on the left, and I would have been concerned, and was, about this, but you do ultrasonography and you can see the drusen there as you turn down the gain. Here's another patient referred for papilledema. Again, elevated optic disc, but caused by drusen, not by increased intracranial pressure. CT scan can be used to diagnose buried drusen. After all, they're calcified, and the CT shows calcification very nicely. And you can see when we did that, the little dots of brightness consistent with calcification. When the workup identifies drusen as a cause of elevation, you really don't need to do anything further. There are no systemic or neurologic deficits that are associated with drusen. The main issue, as I mentioned, is to make sure that you make the correct diagnosis of a congenital process rather than an acquired one. Optic disc drusen do not have any treatment. There have been various surgical attempts to treat them. They pretty much resulted in disaster for visual function. So I will just say, don't operate for these things. Congenital optic disc elevation without drusen is much more common than most people know, it's virtually always asymptomatic with no acuity or field loss, but it does mimic papilledema. And you have to look for the various signs of the lack of hyperemia of the disc, elevation of the disc, as I'll show you, without obscuration of the vessels as they cross the disc, no flame-shaped hemorrhages. You sometimes can have subretinal hemorrhages. Fluorescein, as I mentioned, shows no leakage. Ultrasonography shows no drusen. EDI OCT shows no drusen and no retinal-choroidal folds. So here you can see congenital optic disc elevation without any drusen. We looked at this in detail, and these are just elevated discs. Here's unilateral congenital optic disc elevation, no drusen present, but clearly elevated. Finally, I'll just mention that optic disc elevation that is congenital can be associated with both optic hypoplasia and tilted discs. Here's a patient with bilateral hypoplastic optic discs. You can see the small disc with the surrounding abnormality. And on the other side as well, the one disc obviously much more elevated than the other, but simple congenital. Here's a unilateral hypoplastic disc that was mistaken for unilateral papilledema. Unlike drusen, which are unassociated with systemic or neurologic deficits, optic disc hypoplasia is both CNS and a variety of endocrine abnormalities can be associated. And what I'll leave you with this is that if you see a patient, whether it's a child or an adult, with optic nerve or optic disc hypoplasia, that patient really should have a workup that includes looking for CNS abnormalities and endocrine. Tilted optic discs, here's unilateral, bilateral. You can see the elevation appearance. And I won't go into this for time, but this was a patient who was thought to have papilledema and in fact had just tilted optic discs. So in summary, drusen can be visible or buried and cause elevated optic discs. You can have congenitally elevated optic discs without any drusen or from another anomaly. Thank you very much.